Okay, so the anatomy of a needle, be it a tissue biopsy needle, be it an FNA needle, we've just used this for a cyst. So this is a standard Cook FNA needle. This is a 19, just for purposes of illustration. And here's the handle. This is how it will come out the pack. And there are 3 features to it. One is a stylet. The other is the throw of the needle, which is the top lock, and that brings the needle in and out of the sheath, so it go all the way out and all the way back, and this is the lock for that. And the next thing is how far out of your endoscope the sheath will project, and this is the bottom lock. So this may be preset to 3 or 4, that's usually far too far, and I would usually favour 1.5 or 1, and then you lock that, and once that's locked you rarely have to then change that during the procedure, but change that to 1, 1.5, at which point you will see the sheath coming onto your endoscopic view. Once that's done, you're sorted. Once you get down, we're going to put the sheath of the needle without it being sharp, and we're just going to push that out. At that point you may need to push the sheath out a little bit further and then lock it again with the bottom lock, and then you will have an EUS view of your sheath. That's when you finally check with Doppler that you're not near any blood vessels or vital structures. And once you're ready to puncture, remember that if your needle's out with the stylet in, the stylet will blunten your needle, so you need to take the stylet back just a centimetre or so. That then withdraws from the bevel of the needle and the sharp tip. You can then get ready, so little finger and thumb gripping the body of the needle here, and then index finger and thumb on your needle. And what then happens is your hypothenar eminence acts as a brake, so you can stop before you go too far with the throw of your needle. So by now you've got your lesion in view. You're going to very gently pull the needle out, which you'll then start to see on your EUS view, and when it's ready to go, 2 or 3 centimetres depending on how far the lesion is, keeping the needle in view on EUS image the entire time, very importantly, so that you don't damage any other structures. Once you're in, it's time to start your sampling, and that depends on whether you're using a biopsy needle or an FNA needle. So if this was a cystic lesion and a pure FNA needle, we just push the stylet in. That then clears the distal bit of the needle from any contents that's been pulled in on the advance of the needle through the gut wall, which we don't want. And at that point, if it was a cystic lesion, you would just entirely remove the stylet and put the suction on. If this was a biopsy needle, you would want to start sampling. So my first removal of the stylet might be with a slow pull, just to provide a little bit of negative pressure as I advance my needle 2 or 3 times. I would then usually double up with syringe suction. Okay, but for an FNA needle, we would again do a slow pull. Do you want to do that for me? So my first pass would normally be with a slow pull, so a bit faster. And again, changing the bend and flex of the scope with the big wheel to fan through the lesion. Once that's out all the way, yep, we can then just show the suction. So these are the, I might just lock at this point, because if my assistant's about to put a syringe on, we don't want any pressure down onto the needle. That just screws on. Just be really mindful that it's very easy to get the screw thread wrong at the top. So if your needle is bent or pointing in the wrong direction, you've probably not on the screw thread properly and you'll lose your suction. So this is with the two-way tap closed. Once I'm happy, I would then ask my assistant to open that up, and then on you go with your suction, your throws of the needle. Typically for an FNB, I would do 3 passes into a solid lesion with up to 5-10 throws of the needle. You can obsess about the exact metrics of this. I'm not one to do so. With an FNA needle, where you're trying to get cells, you might do significant increased number of throws of the needle through a solid lesion. But as I say, increasingly we've moved over from FNA of a solid lesion towards FNB. Once you're finished, importantly, take your suction off and also take the syringe off. That then removes any negative pressure from the syringe so that you're not pulling up contaminants from the gut on your way back, which may upset your cytologists, then back with your thumb just to remove that needle back into the stellette. You're now safe. Remember to lock the needle for sharp safety, and then that will unscrew at the bung and out it goes, ready for your next throw, or next pass rather. Thank you very much.